can save energy in your respiratory system, move off to expending energy somewhere else, and you'll have your autonomic nervous system via the circulatory system, via your hormones, keeping your airways dilated while you're exercising. So over here, the mechanism of action. Alpha 1s are going to activate IP3, so inositol triphosphate, that comes from phospholipase C in your plasma membrane, but it goes into the cell as it's hydrophilic. You also have calcium. Calcium can come in from channels, from extracellular fluid, or it can come from intracellular stores in areas like sarcoplasmic reticulum. So IP3 calcium's effects will be usually excitatory. For alpha 2s, they inhibit cyclic AMP. Cyclic AMP is a second messenger that generally is exciting the cells. So if you inhibit its production, then the cell is going to have its metabolic responses dampened down, so inhibitory. In the heart, you're increasing cyclic AMP, so increasing second messengers increases downstream phosphorylation of proteins and therefore excitation of the cells. And here you've got the same thing happening with the beta-2 receptor. You're activating cyclic AMP, but downstream you're getting inhibition. So here's the thing that you have to remember about second messenger systems. They are doing something to protein kinases. If they stimulate the protein kinase and it phosphorylates the protein, then that phosphorylation could be excitatory. But if you phosphorylate a protein and it interferes with the protein's function, then it's inhibitory. So the same type of internal response, depending on what the phosphate does to its target protein, will either be excitatory or inhibitory. So it's the intracellular proteins and how they're affected by phosphate that is the difference here. The autonomic nervous system, emotional state. You know that you can hyperventilate, you know your heart rate pounds when you get emotionally disturbed or anxious. And so these emotional states, that's the limbic system that we learned about last semester. Limbic system goes out to that frontal lobe. That prefrontal area then feeds back to your hypothalamus. And then your hypothalamus is sympathetic and parasympathetic nuclei, or sympathetic and parasympathetic nuclei, then influence the brain stem, and then the preganglionic, and then the postganglionic. So anterior, parasympathetic, anterior medial, posterior lateral is your sympathetic nervous system division. Medulla is stimulated by the hypothalamus, and then the medulla directly will stimulate the preganglionic, which is your autonomic output to the targets of the autonomic nervous system. The autonomic reflexes that we talked about, urination, defecation, penile erection, those are integrated at the spinal cord. So you're sure we just kind of throw that in at this level. The summary for studying, I'm going to leave you to look at this on your own. It kind of summarizes everything that you want to know about origin of the pre- and post-ganglionic fibers, length, neurotransmitter, release, dominance, receptor types, all of that is summarized here in this table. Some interesting things about what you might come in contact with. As far as I know, there was one black widow spider that I know about on the island. It was in a cage out in Mokulea church camp. And I don't know how come at that, I was small kid time. And they told us to see that something on the belly, that's the indication that it's a black widow spider. But she's been demonized, whatever. The venom her sac was taken out, and that's why they could have it, I guess. I don't know who took the sac out, but anyway, we probably won't be coming in contact with black widow spiders, but you never know because things come in and they show up on the island. So black widow spider venom causes an excess release of acetylcholine. Why would that kill you? Stimulates your heart via sympathetic nervous system. What else does it do? Sorry, this is going crazy. What? What kind of spasm? Muscle spasm. What kind of muscle? Skeletal muscle. How would spasm in your skeletal muscle kill you? Your diaphragm spasms. What else will spasm? What else besides diaphragm works on your respiratory system? Intercostal muscles. So if you have your skeletal muscle that runs your respiratory system in spasm, you can't get air in and out. Mostly you can't get air in. So if you have excess release of acetylcholine and it will affect your respiratory muscles, you suffocate. Botulinum blocks acetylcholine release. So how does that kill you? Flaccid, not flaccid spasm, but flaccid muscle. So it's called flaccid paralysis. The muscles are just not able to contract at all. And if that's your respiratory muscles, you can't get air in and out and suffocate. So if curare blocks acetyl receptor function, so what kind of paralysis is that going to cause? Spastic or flaccid? Flaccid, because acetylcholine can't stimulate the receptor, therefore the muscle will not contract. So Amazonian Indians, they discovered this curare, they put it on their little darts and they shoot the animal up in the tree and its muscles will go limp and it fall out of the tree, and then they had their meal. They go and cook it and the cooking would denature the protein, the curare, so they wouldn't get the poison. Organophosphates inhibit acetylcholinesterase. So what kind of paralysis does that cause? Spastic paralysis, because acetylcholine stays in the synaptic cleft longer, stimulates the muscle longer, the muscle does not relax, therefore it's spastic. Myasthenia gravis is destroying acetylcholine receptors. So what kind of paralysis? Flaccid paralysis. What it actually does, this autoimmune antibody binds to the receptors, cross-links the receptors, and then the cell says, hey, something abnormal, takes it back, downregulates the receptors, and then destroys, the cell actually destroys the receptors itself. Because it assumes, since they're all clumped together, that there's something wrong with them. So myasthenia gravis will kill you because of that flaccid paralysis. Okay. We do have some time to go on to the blood chapter.
Oops. Oh, she skipped so many.
We is a good thing because if you're in lab, you're starting with that lab next week. So we should get a little head start on that today. So kind of no-brainer, what is your cardiovascular system there for? Moves your blood. What does your blood have? Red blood cells. What do the red blood cells do? They carry oxygen, they carry CO2. So they're distributing oxygen and also carbon dioxide. Anything that goes into the blood, like hormones, is going to be distributed. Nutrients, ions, also in the blood. The waste products like carbon dioxide, other metabolic waste like your muscle, creatinine will then go to the kidneys. A lot of heat is dissipated by the warm blood going through, being filtered by the kidneys, and then the warm urine coming out when you have your nutrition response. Lungs get rid of the CO2. Lungs also get rid of a lot of heat. GI system gets rid of heat, gets rid of all the digestive waste products. Skin will get rid of urea, which is a byproduct of muscle metabolism. Gets rid of ions. If the sweat rate is high enough, it will actually conserve them during low sweat rates. The leukocytes, the white blood cells, use the bloodstream to move around, but most white blood cells can get out of the bloodstream, and then they actually use the lymphatic circulation to move around your body. So their job is to go out into the tissues and look for things that shouldn't be there and then try and control it. So by the way, if you haven't gotten your flu shot, and I haven't either, you need to go and get it because apparently this flu season is going to be a nasty one. So you want to have a little bit of backup via attenuated virus injection. Flu shots will only be good for that season because the collective antigens that they put into the shot are based on what last year's flus were, and so their best bet is that those are going to be hanging around in some shape or form the following year, so let's immunize you to those. So there's no guarantee that there's not something brand new out there, but the people who are dying haven't had their flu shots, and the people who are surviving have had their flu shots, so it sounds like it's a good idea to get a flu shot. Okay, big guys will have more blood than small women. Men have more muscle mass, they have more bone mass, and therefore they have more vascular system. And to fill that, you need more blood. So they generally weigh more, they have more lean body mass, and therefore they have more circulatory volume, and so they have between 4 and 6 liters of blood. A lot of textbooks will just show you the average, which is 5. Females, being smaller, having less muscle mass, will have less blood volume, so from 4 to 5 liters. Hypovolemia means your blood volume is lower than it should be. It could be due to dehydration. It could be that you hemorrhaged and lost blood due to leakage. Normal volemic, you have normal volume for your body size. Hypervolemic means you have too much blood volume. That could be you went out and OD'd on sodium and still OD'ing on sodium today. And so you are retaining sodium, and therefore water is staying in your extracellular fluid with the sodium, where sodium is partitioned. It also could be a malfunction of the renin-angiotensin-aldosterone system, RAA. So we'll be talking more about that when we get to the kidneys. So renin is an enzyme that the kidneys release, and it activates angiotensin, which then releases aldosterone at the adrenal cortex, which causes sodium to be reabsorbed by the kidneys. So it could be you're consuming too much sodium on a regular basis, and the kidneys just can't get rid of all that you're putting into your mouth. Or it could be that this system is screwed up and it's reabsorbing sodium when it actually should be allowing it to be excreted. pH of the blood, neutral pH is 7, and if blood's pH is 7.35 to 7.45, is it acid or base? It's alkaline, it's base. If your blood pH is not maintained between 7.35 and 7.45, what happens? You don't necessarily die right away, but you get very sick, and ultimately you can die. So it's a good thing to have buffer systems. Your blood is 100.4. So if you stuck your thermometer into your bloodstream, you'd have a fever. But you don't, because you usually take oral temperature or you take the ear temperature, and so you get influenced by air. You get less influence in your ear when you take the temperature of your tympanic membrane. So you don't have a lot of convection going on in your ear canal. But being that you're breathing all the time, your oral temperature is going to be lower than your core body temperature. If you took a rectal probe and shoved it up there, then you get a reading that's close to 100.4 as well. So very little convective heat loss in that area. Viscosity, blood is sticky. You know that. You cut yourself and it kind of sticks to your skin. Unless there's a high flow rate, it coagulates right there on your skin and kind of there's a little ball of blood there. So it's not flowing really fast. It has a viscosity 5 times that of water, which is your baseline of 1. Plasma, if you take the proteins out, you take the cells out, and then you take the viscosity, it's close to water. And so you'd have glucose, you'd have some other ions there. Some proteins besides the clotting proteins might still be there. And then you'd have a viscosity very close to water, which is primarily what the serum is once you take the clotting proteins away. The transfusions, anybody have ever received a transfusion? Nope, good. Usually you use transfusions if somebody is hypovolemic, probably due to hemorrhage of some kind. Or surgery, there's blood loss from surgeries. You can buy time by infusing fluids with carbohydrates, dextran, glucose and saline. Dextrans, which are carbohydrates in saline, goes in. You can buy time until you can get a blood transfusion. But you want to expand the plasma volume so that you maintain your blood pressure and delivery of blood to the brain. Erythroblastosis fetalis, big name for oops, you screwed up and you had an Rh negative mom who had a baby with a Rh positive dad, and nothing happened to the first baby, but she didn't catch it, and the second Rh positive baby, then the mom has made antibodies to this D antigen, and they're small enough to cross the placental barrier and get into the baby, agglutinate the baby's red blood cells, and then they're hemolyzed. So hemolysis of the erythrocytes, that's the blastosis, that's the explosion. So it's also called hemolytic disease of the newborn, more user-friendly description. So the treatment is you give a medication called Rogam to the mom after the first pregnancy, and that inhibits her immune system from forming the antibodies. And so the second pregnancy is fine, and then you need to, if that's an Rh positive baby, you need to give the Rogam again. So every time she has, the Rh negative mom has the Rh positive baby, you need to give this Rogam to prevent the antibody production, which is really easy because they used to have to transfuse the baby in utero. That's not healthy for the baby or the mom. Other reasons to give transfusions: dilute toxins that have gotten into the body. So drug poisoning or autoantibodies that are in the circulation. If you put in blood that doesn't have the drug or blood that doesn't have the antibody, you dilute the antibody in the circulation. It's less likely to have effect. Blood donations. How many of you donate blood? It's about right. About 2% of the population donate blood for everybody else who needs it. A lot of cancer patients, a lot of people going in for surgery that are too sick to donate their own blood. Ideally, that's the best. That's an autologous transfusion where you donate your own blood ahead of time and they store it and then retransfuse it into you during the surgery. You donate about 1 pint, so if you are below 110 pounds, you are automatically not allowed to give any blood because they figure 1 pint in your body is too much, too great a percentage. You get lightheaded, pass out, and they don't want to be liable for that. So if you're a small person, that's an automatic, sorry, can't do that. Red blood cells and plasma will be separated, platelets will be separated, clotting proteins will be separated. Generally, it's very unlikely to be giving a person whole blood. Giving them red blood cells if they need oxygen carrying capacity. Give them clotting factors if they need help with clotting. You give them the plasma if they're hypovolemic due to plasma losses and the red blood cell concentrations are okay. So you can separate these things out and then individually give more than one, can give to more than one individual patient. So red blood cells, they have like an antifreeze that they can use to preserve the red blood cells for a longer period of time. Why can't you actually freeze red blood cells? What happens to water when it freezes? It expands, and so the water in the red blood cell, if it expands, then what happens to the red blood cell membrane? Lysis. So you probably won't know it while it's frozen, but then when you thaw it, then you're going to see all this hemolysis, and you can't give the red blood cells anymore, they're non-existent. So you use an antifreeze, I forget what it's called, but it might be in your textbook. Anyway, it will freeze at a very low temperature so you can store them for a long period of time. Plasma you can actually store via refrigeration, or you can freeze it, or you can freeze dry it and then reconstitute it and put it back into a patient. So this you can keep for very long periods of time. White blood cells, platelets, and then plasma proteins, those are also components of the blood donation. Plasma proteins, you're primarily going for the clotting factors for most of the people who need plasma protein. But albumin could be helpful to a person who has edema, severe edema, because this is helping to keep water in your circulatory system. Immunoglobulins could be helpful if somebody's immunocompromised. Enzymes, I'm not aware of people having those given to them, but I suppose they could. Platelets, if you have clotting problems, you give them platelets. White blood cells, not aware of them being transfused, but they might be. Okay, so how many of you have actually spun blood down? One person, two people. You take the blood, you put it in a test tube. The test tube generally will have an anticoagulant coating already, so it's going to interfere with the clotting proteins in the blood so that you don't coagulate the blood when it's in the test tube. You don't have to if you want it to clot, and sometimes you do, then you can just take it, you can either put it on the side and just let gravity take its course. Because what is blood? What are cells in the blood? Are they dissolved in the blood? No. Are they a colloid in the blood? No, because they're not a protein. So they're actually what? Suspended in the blood. So gravity over time pulls them down to the bottom and you get plasma on the top. And that's what you see on the, well, it's in maybe your other textbook. So you have a suspension of blood cells. You also have, so all these, the platelets, the white blood cells, red blood cells, these are all suspended in the blood. If you centrifuge this, then the fact that these cells have nuclei, they tend to go to the bottom of the test tube and the plasma will go to the top of the test tube. Platelets, a lot of platelets in the blood. They're a very small percentage of the formed elements in the blood, less than 1%, but there's huge numbers, 500,000 per cubic milliliter. White blood cells, we have monocytes and we have what are called granulocytes. They have either reddish brown staining granules or dark purple staining granules or kind of neutrally azurophilic, kind of purpley pink staining granules. The dark purple staining granules, you can't even see the nucleus until the granules have been released, then you see the nucleus. So when you see something really, really dark purple and it looks like it has little chunks on its surface, that's a basophil. Very rare you're going to find one in peripheral blood. You'll see about 20% or so of these lymphocytes. They'll have a large nucleus and very little cytoplasm around them. You'll see maybe 5 to 8% of the monocytes. So they're usually, their nucleus looks a little more airy, a little less dense than the lymphocytes nucleus. Kind of a horseshoe shape to it. And then it's usually the biggest of the cells. The granulocytes are the next biggest, and then the lymphocytes are the smallest. When you can see the nucleus right away, you know you have either a neutrophil or you have an eosinophil. You look for the granules and look at the stain, and you look at the numbers that you're seeing. If you see a lot of the dark purple nuclei and they're kind of all different shapes, some of them will actually have small little filaments, so they look like multiple nuclei, but they're on high magnification. You can see they're all connected together. That will be a neutrophil. It also has a nickname called a polymorphonuclear leukocyte. So big word for it has many shapes of its nucleus. That's what polymorphonuclear leukocyte means. So if you work in a blood lab, you'll be talking about neutrophils maybe, but you'll probably be talking about PMNs, which is this polymorphonuclear leukocyte. So these will be the most numerous, anywhere up to around 70%. But if you got an infection, the numbers can go even higher than that. If you've got a parasitic infection or some kind of allergy, eosinophil levels will go up. But generally you have less than 5% of that, less than 1% of basophils, and around 20 or so % of the lymphocytes. Red blood cells, if you take the tip of a pin and stick it into the blood and pull it out, you got about 1 million red blood cells on that tip of the pin. They're very, very small, and there's huge numbers in your circulatory system. Red blood cells constitute of the formed elements about greater than 90%. What does that say? 99.5%. So because students sometimes get confused because this is a piece of a cell, they say it's not a formed element, but it is considered a formed element because it is from a blood cell that is stuck in your bone marrow. So platelets are formed elements, white blood cells are formed elements, red blood cells are formed elements. When white blood cells leave the circulation and go out into the tissues, they are still formed elements of the blood. I had a student who argued with me way back in the years ago. Macrophage is not a formed element of blood. I said, well, where does it come from? From a monocyte. Where is the monocyte? It's in the blood. Okay, so what's your problem? Well, it's got a different name and it's out in the tissues. Warning. Macrophage was a monocyte. Its name changes, its function changes, it goes out into the tissue, but it's still a formed element of the blood. Okay. Dissolving oxygen. Dissolved oxygen, that's what is dissolved in the plasma. You can't live on that. You've got to have red blood cells or you're going to die. And you've got to have enough red blood cells or you're going to be really sick because you're not going to have oxygen carrying capacity. But it's the dissolved oxygen that diffuses into the tissue. So here comes concentration gradients again to haunt you if you thought you were over that when you got out of 301. Nope. You got concentration gradients all the way through this semester as well. The O2 is primarily carried by the hemoglobin in the red blood cell, but there is oxygen that will diffuse off the hemoglobin and into the cytoplasm of the red blood cell. It will equilibrate with the oxygen in the plasma, and that will equilibrate with the oxygen in the interstitial fluid, and ultimately that will equilibrate with the oxygen that's in the tissues. So there's a concentration gradient for oxygen to go into the tissues, and vice versa for carbon dioxide. Carbon dioxide is produced in the tissues, so it'll be high there, it'll be low in the blood, and so it's going to diffuse down this concentration gradient into the blood. Hematocrit, you might have heard that term, actually know what it means. This is a reading that you get if you put blood into a capillary tube and spin it down, and then take, you can put it on a ruler and determine how much volume, how many millimeters actually, but it equates to milliliters of blood you have in that test tube. And you go from plasma down to the end of the packed cell, and then you look at the fraction that is packed and the fraction that is plasma. And usually what they'll call the formed elements is the hematocrit. In males, you'll have a hematocrit that is probably around 45% of the total volume that you have in your capillary tube, and that will contain around 5 to 6 million red blood cells per microliter. Okay, so if you had 100 microliters of packed red blood cells, every little microliter would have 5 million red blood cells in it. So that's how small they are. That's why this one little dip into the blood, you get at least 1 million red blood cells. For females, because they're smaller and also they don't have as high a testosterone concentration, they're going to have less red blood cells, around 42%, which turns out to be around 4.8 million red blood cells per microliter. Most correctly, when you look at all the white blood cells that are crammed down after centrifugation, you should call that packed cell volume, because hematocrit really should be saved just for red blood cell concentration. But a lot of times out there in the clinic, they're going to use hematocrit to mean everything that gets shoved down to the end by centrifugation. So volume, packed red blood cells, BPRC, you might see that on a clinical lab sheet, or PVC, you might see that, and then HCT for hematocrit on a clinical sheet. Okay, so pick up with blood smears on Tuesday.